Hello everyone, welcome to OzPIP's and IDFA's webinar to acknowledge Rare Disease Day 2025 and raise awareness of primary immunodeficiencies. Before we begin, we would like to acknowledge the Wurundjeri people of the Kulin Nation and the Dharawal people of the lands on which we are presenting from today and pay respects to their elders, past, present and emerging. We extend our respect to any Aboriginal and Torres Strait Islander peoples who are joining us for this webinar. This webinar will be recorded and shared on the IDFA website. This webinar invites leading clinicians and medical researchers to share their visions for early diagnosis and novel treatments for immunodeficiencies and foreshadowed impacts on patient quality of life. We will hear about future directions for care and potential impacts for people living with immunodeficiency. Members will also be invited to share their visions, hopes and aspirations for the future and showcase key life so far moments celebrating how far diagnosis and treatment has come and what is now possible. So the topic areas and speakers for this evening are Early Diagnosis, Future Vision and Research, presented by Dr. Melanie Wong. Transition Care, Future Vision and Research, presented by Dr. Elisa Kane. Future Vision and Research into Immunotherapies, presented by Associate Professor Teresa Cole, and My Future Me, presented by Thomas and Lauren. I'd first like to take the opportunity to introduce myself. I am Emily Edwards, and I'm the Vice President of OzPIPs Inc. and a medical researcher in the field of primary immunodeficiencies. OzPIPs is an Australian patient-led charitable organisation. Our purpose is to advocate and support people with primary immunodeficiencies and associated chronic illnesses and their families in Australia. Working in partnership with patients, carers, clinicians, government and other patient organisations like IDFA, we aim to achieve our vision, which is to enable equitable access to diagnostics and treatments for PID. Through this, we hope to enable earlier diagnosis and more effective treatment, which will improve the quality of life of patients and their carers. For this webinar, OzPIPs is partnering with IDFA. So it is my pleasure to introduce Carolyn Dews, CEO of IDFA.
Thank you, Emily. The Immunodeficiency Foundation Australia is a member-based organisation that represents people living with primary and secondary immunodeficiency. We are a national peak body with more than 2,000 members. Our vision is a future where primary and secondary immunodeficiency are diagnosed and treated early, with people supported by clinicians, community and government to allow optimal quality of life. As Australia's peak patient organisation, our strategic priorities are education and awareness, care and support through building community, driving change through advocacy. We hope you enjoy the webinar and find it useful.
I'm Melanie Wong. I'm a clinical immunologist and immunopathologist at the Children's Hospital at Westmead in Sydney. I'm also the chair of the Medical Advisory Panel of IDFA. Today I'm giving a short presentation on early diagnosis, future vision. What are we initially talking about? Primary immunodeficiencies. We now actually officially refer to these as inborn errors of immunity, recognizing that genetic defects of the immune system commonly don't just cause predisposition to severe or recurrent infection, but to a wide range of overlapping immune problems, which include severe autoinflammation, autoimmunity, allergy, and malignancy. Recognition of the diverse ways that PIDs or inborn errors of immunity affects individuals is absolutely essential to early diagnosis and optimal treatment. I refer you to this nice pictorial diagram summarizing the classes of inborn errors of immunity as we see in a list that is updated on a 2-yearly basis, the IUIS classification of inborn errors of immunity. And here we see that some of the things that we initially thought classical, including the combined cellular and humoral immunodeficiencies, the antibody deficiencies, deficiencies of phagocytes, as in neutrophils, both number and function, have been and complement have been progressively added to by other categories, which include immune dysregulation, autoinflammation, the defects of innate and immune systems, bone marrow failure syndromes, and more recently the phenocopies, as in things that look like the primary genetic abnormalities that we've been identifying, which are the result of mutations in our genes that occur after we're born, and also to autoantibodies, making the whole system much more complex for diagnosis and also in therapy, but in many ways also helping us learn from what we've seen for primary genetic problems in order to treat things that look like them. So what are some of the exciting things that are happening? And they are truly exciting trends in both diagnosis and treatment that are actually changing the outlook for and the quality of life of people with inborn errors of immunity. And just a short list of things I've thought about, some of which I'll talk a bit more in detail, but just to think about. We have earlier diagnosis of inborn errors of immunity, the introduction of newborn screening, exponential increases in genetic testing, awareness of medical, paramedical and the general community about inborn errors of immunity. We're seeing advances in medical therapies. These are driven often by the understanding of the mechanisms and pathways of disease, allowing for targeted therapies, biologic agents, small molecule inhibitors, repurposing of medications that we've previously used for other things, for newly identified syndromes and symptoms, and improvements in the administration of immunoglobulin replacement therapy. We're seeing advances in stem cell transplantation, improved safety, including the addition of supporting therapies. We're seeing more detailed HLA testing, technologies which reduce the incidence of graft versus host disease and improved engraftment. We're also seeing advanced cell sorting strategies that has enabled the use of parents and other donors in haploidentical transplants. There are advances in thymic transplantation, including access, which is an important thing for patients that are in Australia, for example, to access therapy overseas. And lastly, significant advances in gene therapy. So, increased awareness of potentials of PID is absolutely essential. About 1 in 10,000 people are affected by PIDs, and this is a likely underestimate due to misdiagnoses. There are a wide range of presentations, as I've alluded to, and so some people go undiagnosed for many years. And it's important that physicians in all medical disciplines need to be aware of PIDs in their patients. For example, their patient with neuromyelitis, inflammatory bowel disease, severe food allergy, or early onset autoimmune diseases or B-cell lymphomas, other conditions may actually have a primary immunodeficiency underlying their subspecialty diagnosis. Early diagnosis allows for early treatment, potentially avoiding the progression to irreversible complications. Definitive diagnosis on a genetic level actually provides information about prognosis, it guides treatment decisions, it enables genetic counselling and reproductive choices, and provides the opportunity for predictive testing of families and relatives at risk. We have challenges, though, to genetic testing, and that includes the cost, the attempt to determine what is truly pathogenic versus a variant of uncertain significance when we find a mistake, and decisions as to whether a genetic mistake is monogenic, in other words, the primary cause of the problem, polygenic, that is contributing along with other genes, whether it's epigenetic, so brought about by environmental influences, or somatic, changes in our gene after we're born, particularly in the context of what are called clones, which may or may not be malignant. So there have been substantial improvements in genetic testing. We now have available to us next generation sequencing, which is faster and cheaper than the more traditional Sanger sequencing of single genes that we've had in the past. And this is especially useful when multiple genes could be the cause of the problem rather than a single gene. Research on disease-causing genes has uncovered a tremendous phenotype diversity, in other words, what people present with to their doctors. And we know now that there are over 555 distinct disease entities across about 504 distinct genes, included in the last update of the IUIS classification. Recognition that defects in immune genes can lead to this myriad of clinical presentations unrelated to susceptibility to infection has led to major extensive collaborations across disciplines, and this has led to new opportunities of treatment, improved multidisciplinary care, and that in turn leads to better outcome for our patients. The bottleneck, as I've alluded to, is that when we have next-gen sequencing results, we need to be meticulous in validation of the various findings in order to determine pathogenicity. This is particularly the case for genetic counselling, for planning for pregnancy, and also prenatal genetic diagnosis, which might enable us to choose affected or unaffected ova, and therapies which are targeted to certain immune pathways, particularly since some of those are difficult to access in our current environment. The importance of determining pathogenicity is not just for the novel genes that we might be finding, but also for the novel variants, in other words, mistakes in the genes that we already know about. This graph is quite amazing. So over my practicing life, I've seen the cost of sequencing of a human genome, in other words, all the genes that are in the human body, acknowledging that the genes are our blueprint for making proteins, and the proteins are the things that make up our body physically, and also the components of our bodies that work in our case the immune system, such that we have conversations between different cells, different components, such that we have signaling and lots of changes that are dependent on the proteins that are in our body. And so in the early 2000s it cost about $100 million to sequence the genome of a single person. And this was based on laborious techniques such as Sanger sequencing. And then with the evolution of next-gen sequencing, there was a rapid fall in cost, which was further dropped by improvements in next-gen sequencing, so referred to as third-generation sequencing, such that these days a genome costs about $1,000. $1,000 is still a lot of money. And hence the inequity of access of individuals to get their genome sequenced, and therefore the identification of what might be complex inborn errors of immunity. And if we actually look at what we have available to us at the moment, from a diagnostic perspective, we can routinely order tests based on either Sanger sequencing or next-gen sequencing in our diagnostic laboratories. Issue is, can we access it? Can we pay for it? Who pays for it? Who does the reporting? And what detail have we got in order to determine whether the reporting of the implication of a gene at this moment in time will actually change in the future as we have more information available to us. We also have a myriad of other genetic technologies that we can use to determine other causes of our inborn errors of immunity, and these are progressively crossing from a research front to a diagnostic front. Again, hugely exciting for the future. So proteomics, in other words, looking at the proteins that are being made at the end of that line that I was describing. Epigenetics, looking at the effect of the environment. We're looking at optimal genome mapping, and also single cell sequencing, so looking at the genes and the RNA and what is going on in the single cells themselves as opposed to all the cells in the body. And finally, RNA sequencing, looking at that in between the genetic code of DNA and the proteins that are finally produced, the RNA transcription of DNA in the middle. Many exciting technologies. And we're seeing this in the increasing recognition of the genetic causes of inborn errors of immunity. So on the graph on the left shows the exponential increase in the number of genes identified as causing inborn errors of immunity from single digits in the early 1980s to close to 500 a couple of years ago. The graph on the right demonstrates that in a 3-year period between 2019 to 2022, across those categories of the IUAS, categories of inborn errors of immunity, the blue were the genes that had been previously identified, and the red ones were across the newly identified genes, and there were substantially more defects in the intrinsic and innate immune system, and also in autoinflammatory genes identified across those 3 years than in the other categories. And then more recently, over the last 2 years between 2022 and 2024, there were 54 new genetic defects linked to inborn errors of immunity. That's over a tenth of what was existing before, exponential increase. And although the majority of people have an primarily antibody mediated defect, we're actually finding that only 2 new genes were described in the last 2 years, in contrast to about half of the new genes identified linked to either immune dysregulation or defects in the intrinsic or innate immune systems. And so we're able to see more diagnoses for people that we have not actually traditionally had the tests to be able to identify what was causing their immune problems. Whereas, for example, an antibody deficiency, we can actually often measure the actual level, see that they're low. We can measure that people don't actually respond to vaccination and identify them that way, and give these individuals a diagnosis that can lead to a treatment, even though at the moment probably only about a third of them at this stage we can actually identify a genetic defect in. So many advantages of finding genetic diagnoses. The other thing that's increased is identifying the presence of immunodeficiency, where a gene has been identified in people who've shown up in other contexts, to other subspecialties, and linking those things together. Moving along to newborn screening. We've had the introduction of newborn screening for severe combined immunodeficiency, which is one of the most severe forms of immunodeficiency. And this has enabled early detection and resultant early preventative and definitive therapy, which has reduced the burden of disease from infection and increased survival. I'm really pleased to note that as of May of last year, all states and territories of Australia include SCID in their newborn screening test, meaning that all babies in Australia are now screened for SCID by detecting low levels of TREX, so T cell receptor excision circles, which have indicated the absence of naive T cells. And this happens soon after birth before they become sick. In some states, there is also screening for agammaglobulinemia, and that's both X-linked and autosomal recessive in nature, and this is screened by the very low levels of CREX, and they indicate the absence of B cells. There are barriers to other immune disorders being added to the newborn screening programs, and they include costs, technology, and justification issues. But there are trials underway in Australia for the addition of screening for pathogenic variants in what are considered clinically relevant genes, and this includes quite a number of inborn areas of immunity. And so this is an area that will hopefully increase access to newborn screening for in the future. This newborn screening, however, does not actually replace the importance of awareness. So early screening with at least the routinely available tests needs to be done for those people with suspicious presentations and infants with a family history of inborn areas of immunity, regardless of our reliance on newborn screening. And then going on to gene-based therapies. When we do identify that a gene is the cause of a defect, what can we do about it? We can go to gene therapy as we traditionally know it, and that is transferring a normal gene a normal version of the gene that has been found to be defective to the person affected. We can do gene editing, which is actually taking cells from the person who has the defect, manipulating the mistake, correcting it, and putting it back in. There are RNA-directed therapies where we can introduce things called antisense oligonucleotides, which can skip over mistakes and make the body produce the proteins that it couldn't make before. And there are also inhibitory RNA molecules that actually stop the overproduction of things that are causing excessive problems with the immune system, because the machinery to stop or control production is defective. All very exciting areas that are just really beginning. However, the progress is slowed by multiple things. And so in the area of inborn areas of immunity, we have had successful clinical trials of viral vector gene additions, and that is that first group that I spoke about in ADA SCID, X-SCID, Artemis SCID, Wiskott-Aldrich syndrome, and CGD. We've had promising clinical trials that are ongoing for RAG1 SCID, leukocyte adhesion deficiency type 1, and IPEX. And also proof of principle for gene editing, so that's CRISPR technology, has been demonstrated for X-SCID, X-linked CGD, CD40 ligand, CTLA4, XLP, RAG1, and Wiskott-Aldrich syndrome. And we know that, or we think that, for genetic defects affecting T cells, it might actually be safer and easier to target the T cells rather than targeting all the stem cells within the body. This is an area yet to be tested out, but it's exciting to think about the possibilities. Now, unfortunately, as I alluded to, it takes time and there are issues. So gene therapy for ADA SCID, one of our most successful gene therapy processes, was first and is actually so far the only gene therapy that has actually gone to market authorization in the European Union. That happened in 2016, and there have been moves to actually add others, but unfortunately they've been stopped because it was thought to be at this stage financially not viable. So we know that the current for-profit model of market authorization and commercialization isn't fit for purpose in the rare diseases such as inborn errors of immunity. And global collaboratives are looking at alternative strategies to make it work. So biologics is one of those areas that most people have not got don't have a good handle about what we're actually talking about. Biologics, small molecule inhibitors, and other very exciting technologies that we now have access to. And this massive expansion in all fields has had significant impact in many fields, including cancer, inflammatory disorders, immunologic disorders, and infectious diseases, all of which have impact on our patients with immune problems. So biologics are, in the most simplistic way of thinking about them, made in living systems and encompass a wide range of therapies, including monoclonal antibodies, vaccines, growth factors, and cell therapies. This is exciting, it's life-changing, and outlook-changing. And this is early days for assessing the safety and especially the long-term outlook as far as these medications are concerned, but they're being used more and more. The barriers for access are to equity of access. First of all, we need to get a diagnosis. We need to be able to think of the pathways that are most likely to be affected. Cost is a major issue. Very few have TGA approved or PBAC approved funding in Australia for inborn error of immunity indications, and often we need published reports or at least the results of clinical trials in order to actually support their approvals for such funding. And so patients often get access to these therapies by getting into clinical trials, compassionate access schemes, hospital drug therapeutic committee access. And so there is a lot of work that needs to be done to access some of these amazing therapies. And so in conclusion, we are looking to a bright future where and what I would like to see is all inborn errors of immunity rapidly diagnosed and successfully treated as early as possible. There are hurdles to cross, however. So we know that early diagnosis is improving with improved costs, research, and technology. But people still need to be aware, and the community and clinicians in particular need to be aware of who to test and who to advocate for. We are increasingly understanding disease pathways, and that opens us to opportunities for targeted therapy. What was previously thought to be treatment for a very, very, very small number of disorders is now standard care for many more, and we need to harness that ability to do that. Ongoing considerations, especially in the rare disease space, are the weigh up of risk versus benefit, cost versus benefit. We need to be thinking about primary versus secondary errors of immunity, and that actually has implications about how many people we really are actually treating and advocating for. There are increasing recognition of phenocopies, and it's important for us to continue to include them under the umbrella of inborn errors of immunity, because many require the same treatments, and it turns out that some of them actually do have a primary immunodeficiency caused by a gene defect we haven't yet been able to find. Thank you for listening, and hopefully this will add to the subsequent talks for this period of celebrating Rare Diseases Day.
I'd like to thank the Immunodeficiencies Foundation of Australia for inviting me to speak on this very important topic of transitioning from paediatrics to adult care. I'd like to begin by acknowledging the traditional custodians of our land, the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and to any Aboriginal and Torres Strait Islanders listening to our webinar today. My name is Associate Professor Elisa Kane, and I'm a clinical immunologist from Sydney. I'm talking about transition, which in health terms means the purposeful and planned movement of adolescents and young adults with chronic physical and medical conditions from child-centred to adult-oriented healthcare systems. So essentially, most of you will be receiving your care in a paediatrics hospital with paediatricians and a paediatric-focused care team, and then eventually, as you grow older and become adults, you'll receive your care in an adult-based hospital. In medical terms, we think of transition as starting around the age of 14, and by that we mean preparing for transition. And the physical movement of transition is just part of this, and the process of transition continues into the mid-20s. The goals of a good transition essentially is that the young person becomes independent managers of their own health, and the parents and carers become support persons to the young person, which means a difference in role and a bit of a role reversal. And then together as a team, we help you, all of you, as a family to navigate the new adult healthcare system. Transition can be a difficult time in life for young people because there are a lot of major life changes happening around that age. So you may be sitting your Year 12 exams and leaving school. You may be looking to go on to further education, such as university or TAFE. In terms of relationships, you may be forming relationships or even getting married. You may have to be thinking about your sexual health, having children, and also you may have involvement with drugs and alcohol. And all of this can impact your health. There are certain sets of skills that you need to manage or develop to be able to manage your own health. So it's important that you develop a good awareness and understanding of your own medical history, develop an awareness of the health system and how to navigate it, including things like appointments, have an awareness of your privacy rights, because when you're 18, you're entitled to keep your own medical information to yourself and you don't have to share it with your caregivers. And also start thinking about how you're going to set some boundaries with your caregivers on how much involvement you want from them. Because I think ultimately what the child or young person and parent wants is that the young person becomes competent and capable of looking after their own health. So in terms of your own medical diagnosis and your medical history, it's really important as you grow older that you develop an awareness of exactly what your diagnosis is, how it was made, and have an understanding of why you see which doctor. That you start to understand your medications and what each medication is for and why you're on it. There are also other treatment options that you might consider as you grow older, and you might want to think about how you feel about the current treatment you're on. For example, if you have an antibody deficiency and you're on immunoglobulin replacement therapy, did you know that there are two options of getting this? You can either get it through a drip once a month, and that's called IVIG, or intravenous immunoglobulin therapy, or you can do it weekly under the skin, and that's called SCIG, or subcutaneous immunoglobulin therapy. Some important questions in immune deficiency may be, as I mentioned, do you know about all your treatment options? Do you know what your health might look like in the future? And some of you may have a genetic condition. And do you know what implications that might have for your future health or for your reproductive health? Now, there's a lot of things to consider, and they don't all have to be discussed at the one time. But I think it's important to have an idea of the things that you need to start considering, or the things that may be discussed in the future, so that you can be prepared. Being responsible for your own health also means there are practical aspects of medical knowledge that you need to acquire. So do you know how to make an appointment? How do you advocate for yourself with health professionals? Do you have a sick day plan for when you feel unwell? Have you got your own Medicare card? Do you have your own private health insurance, or are you still with your parents? And do you know how to access government supports? And many of these things your paediatric and adult healthcare team can help you with. Or if you go to the Immunodeficiency Foundation of Australia site, for example, there's a self-advocacy toolkit that you might use. One topic area that I think catches a lot of people by surprise is really just about how our health system works. In the paediatric setting, often the hospitals are fewer in number and they're very well organised with easy access to specialists all on the same location. Once you get out into adult care, there are many more treatment options and they may not all be co-located. You'll also need to think about, what type of doctors are you seeing and what their specific roles are. For example, general practitioners tend to be the person who coordinates all of your healthcare and coordinates all the specialists. You may see various specialists in a hospital or a private clinic setting, for example, an immunologist, a respiratory physician, a gastroenterologist, or a hematologist, depending on what your health is like. You may see these people either at the hospital or in a private clinic setting. And you may also see other health professionals such as nurses, social workers, and dietitians. So I come from New South Wales and our health system is split up into different health districts across the state. So there's, for example, Southwestern Sydney Local Health District, and that's where I work for Liverpool Hospital. There's also Eastern Sydney Local Health District, for example. And each health district will have a number of major hospitals. And if you live in that area, it may be that you go to the hospital within your area, or it may be that due to the complexity of your disease type, you may be referred to a clinician outside of your local health area. So what happens when you get to the hospital and have your first appointment? Because you're new to us as a patient, we would go through your whole health story, essentially from your birth up until the age you are now, and get an understanding of what your current medical health issues are that need attention, go through your medications, your allergies, a family history of other medical illnesses, and also a social history. So we'd like to know who's at home with you to give you support. What do you do with your time so we can help you navigate your health in the context of your own life, what your hobbies are, what your finances are, and also if you partake in drugs, alcohol, smoking, or vaping. People with immune deficiencies are offered regular appointments, and this is so we can help you keep healthy. So appointments are not just for people who have an acute health concern that need management, but we'd like to make sure that all of your health concerns are looked into regularly and that they remain in control. And this allows us to keep you healthy and also manage any conditions as they emerge. And we may also discuss things like your reproductive health. And again, sometimes it might be possible to work the appointments around your work and study, but sometimes it isn't possible, and it's important to realise that your health is important and that sometimes you need to compromise. In terms of the process of transition, you can think of it as having several different stages based on your age and your development. So transition, we say, can start as early as 12 to 14. By this, we just mean that by the age of 12 to 14, when you first become a teenager, you may be able to become more responsible for your own health. And your caregivers and your clinicians may help you to start developing your own self-management skills, because it's good to start early and in a supported environment. So this could be that they encourage you to ask questions about your own health in an appointment, or encourage you to maybe just start by remembering when you need to give yourself SCIG. And gradually you work your way up so you gain all the knowledge you need to move across to the adult hospital and become independent. Physical transition usually begins between the ages of 16 and 18. So a couple of years before that, at the age of 14 to 16, you may start to learn more about your condition and how it affects you. You may start to develop an action plan with your healthcare provider and become aware that there are coordinators in your area that can help you do this transition. And you might start having a conversation with your family and your carers about how you're going to become more independent with managing your own health. You may also start to think about other health factors, like how to live healthy and to deal with things like stress and anxiety, and to think about how you'd like to make decisions for yourself. So by the time you're 16 or 18, you're truly ready to make that leap into the adult healthcare system. By this stage, you should really know about your condition, your treatments, what to do when you're unwell, and to think more broadly about how your lifestyle might affect your health. By this stage, you may be starting to sit very important exams, and you might want to speak to your school about any special considerations that you may be able to be offered because of your health, and start to think about future plans and goals for your health and your work and your education and family. This information isn't something that you need to come up with on your own. Your healthcare providers in the paediatrics hospitals can help you with this, and each state has an organisation that will have resources for you to access and to help you. For example, the Agency for Clinical Innovation in New South Wales has transition checklists for young people. So I'm an adult immunologist, so I'll see you on the other side of transition in my adult hospital. A lot of my patients and their carers express surprise at some of the big differences. Of course, there's a new team of doctors, nurses, and health professionals, and we like to speak to you and retake your story so we get a good understanding of what's happened to you and what your issues are. But rest assured, we have spoken to your paediatric specialists and we know what's going on for you and what healthcare needs that you have.
From our experience, we think we can do better to make the transition process easier for patients and their carers. So, in collaboration with researchers, including myself and others, we at IDFA are running a study to map out the current or recent experiences of adolescent and young adults moving into adult care. We are keen to find out about your experiences, what worked well, what didn't work so well, and most importantly, what you think we could do better to improve the process. We're keen to hear from any person with a primary immune deficiency about to or have already moved into the adult healthcare system from the paediatric system, and also from their carers. We are especially keen to hear from people 16 years to 25 years old and their carers, as you would have had the most recent experience, but we are interested in hearing from anyone who's gone through this experience. If you are interested, the way to sign up is to please contact the IDFA for more information on the study, and we will follow up with you. Thank you.
My name is Teresa Cole. I'm a paediatric immunologist at the Royal Children's Hospital. I'm really glad to be here today to talk to you about early diagnosis, the future vision, and genetic research. I think this talk could also be titled, Where Have We Come From and Where Are We Going To? So we know in the past that we recognised immune deficiencies through what we call the clinical phenotype, so the symptoms and signs that we might see. And this is really how we started back in the 1950s, recognising children with SCID and moving on to then recognise things such as Omen syndrome. But it wasn't until the 1970s that we started to be able to understand the mechanisms behind the phenotype of SCID. So the first described form of SCID was ADA deficiency. And it wasn't until the 1990s, in fact, that we got a genetic diagnosis for the gamma chain receptor or X-linked SCID. And we now know that there are over 20 different recognised genes associated with the same phenotype, so a child that we would recognise as having SCID. It's taken a really long time to get to where we are in terms of understanding of genetics and the testing that we have available. Back in the late 1800s, people started to try and think about the inheritance of disease, but it wasn't until the 1950s that the structure of DNA was described, and it took until the 1970s to have a reliable way of testing with Sanger sequencing, which still has its place today. The Human Genome Project started in the 1990s to try and map all the different genes, but it was not until we got into the 2000s that we started to be able to develop better testing that allowed us to do more comprehensive genetics. We now recognise that there are hundreds of genes associated with immune deficiencies. Every few years, the International Union of Immunological Societies puts out an updated list of where we're up to, and we're getting on for close to 600 these days, stretched across all of the different types of groups of immune deficiency. One of the things that we are really proud of and that IDFA have been a part of, along with many other people around the country, is getting screening for SCID up and running across the country now. It's important to remember that this is not genetic screening. This is screening using TREX, or T cell receptor excision circles. It was first thought about back in the 1980s, but not really developed into a true test that could be used until 1998. And into the early 2000s, some groups in America really started to pioneer its use in screening for SCID. And as many of you will, I'm sure, be aware, we now have this routinely available across all states and territories. And the reason we fought so hard for this is knowing that early diagnosis means better outcome for those children born with SCID. We've got some good data out of America now who have been screening for close to a couple of decades that demonstrated that overall survival is better since the introduction of screening. And that even compared to those that are recognised through family history, that if your child is identified through the newborn screen, then your outcomes are the best that we can currently hope for. So I've talked a little bit about screening for SCID, but what else might we be able to screen for? Before talking more about what diseases we may or may not be able to screen for in the world of immunology, it's important to recognise the difference between a screening test and a diagnostic test. A screening test isn't the final result. It's a test that might be able to highlight a potential abnormality that needs further workup. It's normally something that is reasonably cheap and easy to roll out across a population. It's the sort of test that would be acceptable to many people. And this allows us to identify those that may be at risk and therefore would benefit from further testing. So when thinking about screening for a condition, there are principles as published by the World Health Organization that should be considered. And these are the sort of things that are thought about in the background and were thought about when we were considering SCID screening. So a condition should be important, should have a phase where it can be picked up early before major complications are occurred, and we should have a good understanding of the natural history of the disease so that we know what will happen if intervention isn't in place. There needs to be a reasonable test that is usable, reliable, reasonably cost effective, and there needs to be a recognised pathway for treatment and what intervention would happen if the disease was identified. And then there also are practical considerations around how you can roll out such a screening programme and that it can be managed in a practical way. So moving on from SCID to thinking about other things. So it is possible to screen for B-cell deficiencies, particularly X-linked agammaglobulinemia as an example. There are CRECs, so kappa deleting recombination excision circles, very similar to there are TRECs, and these can be identified through a very similar process through PCR on the dry blood spot. However, this isn't rolled out at the moment because it's still something that we are learning more about, and there do seem to be further impacts. For example, things such as maternal immunosuppression in pregnancy seems to have an impact. And it's really important when we're thinking about screening that we want a test that really doesn't have a high false positive rate, so that we're not calling back large numbers of babies for additional testing, causing anxiety to families to then tell them that it's not a problem. And so this is something that is still being considered. It's also tricky in that at the moment we still don't have substantial evidence that identifying a baby very early in life with XLA and starting immunoglobulin replacement is going to have a significant difference in their outcome. Now, we think as clinicians, recognising and starting any therapy early is likely to be better, but we don't have the data in as much detail as we do for SCID at this stage. So moving on to think about how else we can screen or test for immune deficiency that isn't the TREC or CREC PCR that is available as a test. And what about genetic screening? Well, this is something that around the world is being considered and has been piloted here in research in Melbourne and across Victoria. And so the Victorian Clinical Genetics Service, VCGS, set up a research trial called Baby Screen Plus to look at screening on the dry blood spot normal baby test through genetic technologies to see if they could identify other conditions. Now, this wasn't just immune deficiency. This was a range of other conditions that are significant and have an early impact. So let's think about some of the other conditions that we might come across in the world of immunology. And so we know that SCID meets the criteria for screening as outlined by WHO, and that's why we worked so hard to get it onto the newborn screen. Now let's move on to think about Wiskott-Aldrich syndrome, which as paediatric immunologists is another disease that we obviously think is significant. However, it's a little bit trickier than on some of the other questions when you think about the WHO criteria. So a recognised latent phase or early phase, well, there probably is, but it can be quite long, and not every child with Wiskott-Aldrich syndrome will present early in life, and some may present quite a bit later. I think we have a good understanding of the natural history. At this point, we would have to test through genetics, and that's where it starts to get more complicated, I think. So we still are trying to think about whether genetic testing is going to be acceptable at a population level. I think it's a very personal thing as to whether people think that that's a reasonable method. And there's probably still a lot of hesitancy and need for more education and understanding in the community. In terms of the acceptable treatment, that's also tricky because we know that children with Wiskott-Aldrich syndrome can be very variable in their presentation, some with very few symptoms and some with severe symptoms quite early on. It's also tricky to know exactly how we treat them. Again, because of the range in different presentations and problems, there isn't a clear and standard policy for exactly how we would treat every child. And at this page, we wouldn't know about the cost effectiveness of treating. And then one of our other more recently recognised conditions is another example. So STAT1 gain of function. Again, we recognise as paediatric immunologists that this is an important health problem and that children can be really quite unwell with it. But the early presentation is very variable. The natural history is not well understood because, again, the range of presentation is very broad. We'd have to test through genetics because we don't have easily accessible functional testing at this point that would be able to be rolled out in a screening form. And so that brings up the questions of acceptability of genetic testing at a population level again. And again, then the treatment is very broad depending on the severity of the condition. With some people, this is relatively mild, and for others can be much more significant. It can also be tricky getting a true diagnostic test because we know that some of our functional testing for STAT1 gain of function can be hard to interpret. So just to give an example, you think about perhaps testing a baby and then raising it as a possible question, but not being able to truly answer whether it's a problem or not, the amount of anxiety that that might bring for a family. So genetics is great and definitely has a place in our testing, but it's not always straightforward, and there are some complexities. If we were to move to genetic testing for screening of babies, that would need an entirely different lab structure and different techniques to those employed in the newborn screening labs around the country currently. We'd also need experts in bioinformatic review to look at the data that is generated, which again is a skill set that the current newborn screening laboratories don't have. We know that genetics can take longer to get results because of the complexity and the need to evaluate the results that we're seeing. That might lead to longer, what we call turnaround times. And particularly in screening babies, for example, if you were looking for SCID, you really want to know very quickly so you can intervene. Any sort of genetic testing is likely to be more expensive than the testing that's currently used in the newborn screening lab. And as I've alluded to already, there's significant work still to do on whether this would be acceptable to the public at large. We also know that within genetics there is this concept of variants of unknown significance, so gene variants that we pick up and we're uncertain whether they are disease causing or not. And this can then again lead to further anxiety, particularly if it's in genes where we don't have great diagnostic testing to truly answer the question. So I was tasked with talking about the future, so let's think about where we might be going. I think it's very possible that there will be a genetic backbone to newborn screening somewhere down the line in the future, but at this point in time, I wouldn't like to guess when that will be. I think the thing that we're wrestling with as immunologists and probably in other specialties as well is which are the conditions that really, when you then look back at the WHO criteria, are those that we should be pushing for screening versus those that will remain within the realm of being picked up by clinical signs and symptoms. And I think it's very unlikely that we'll be screening every baby for every form of immune deficiency anytime soon. And so it's very important as doctors that we remember that and don't discount the possibility of an immune deficiency. The work in making sure that the public and general practitioners and paediatricians around us can recognise warning signs for PID really needs to continue, because it's going to be something that we will never need to forget. The future of treatment in the era of improved genomic diagnosis. As I've already talked about with SCID, really the idea of an early diagnosis is early treatment and better outcomes, and we've proven that with SCID as our test case. We really want to be able to do that for other diseases as well. So early initiation of immunoglobulin replacement in those that are going to require it, access to newer targeted therapies that are coming along, considering stem cell transplant for those that might need it before the severe complications occur. And also then access to other novel cellular therapies that are coming online, such as autologous gene therapy and gene editing procedures that will offer cure for more conditions into the future. So very briefly before I finish, just to mention gene therapy, as this is on the horizon for a number of conditions, and there are a range of clinical trials happening around the world for different immune disorders. The gene therapies that we generally have available in trial at the moment are autologous gene therapies, so stem cells are collected from the child. They are manipulated in the laboratory to contain a healthy copy of the gene that has caused the problem, and then they're returned to the child, commonly after some doses of chemotherapy. But we know it's taking a long time. It's many decades since people started thinking about these things. It's slow progress. Each disease needs a lot of research before these things can come to clinical trial and be accessible to patients and families. We need to prove that they're safe and effective, and that takes a long period of time for each of these diseases. So this is slow and steady progress that I anticipate will continue. And finally, just a plug for those who haven't already heard that here in Melbourne, we have been lucky enough to collaborate with the Leiden University Medical Centre through Renew, which is a collaborative funding body, to be able to access gene therapy for RAG1 SCID. And this is being led by my colleagues, Rachel Conyers and Hannah Walker. And we are able to take babies with RAG1 SCID and offer gene therapy here, which is very different to many of the other current research trials which need children to travel overseas. So I'll finish there. I hope I've given you a bit of an overview of where I think the future will be going. I think genetic testing has led to better understanding of immune deficiencies. We know that early identification improves outcomes, particularly in SCID, and we would expect for other conditions as well. We think that there will be other diseases amenable to screening in the future. How that will look is still a work in progress. And we know that a better understanding of genetics and immune deficiency leads to more personalised, targeted treatments that we therefore expect leads to better outcomes for individuals. Thank you very much for your time.
This segment of the webinar will feature members who have been invited to share their visions, hopes and aspirations for the future, and showcase life so far by looking at moments, celebrations, and how far diagnosis and treatment has come and what is now possible. We are excited to have them join us this evening to share their story.
I am Thomas Stein. I currently live in Sydney, Australia. A little about myself is that I'm currently 19 and was originally from Wellington, New Zealand, but moved to Australia in 2019. At that time, I moved to Canberra. I am a photographer which mainly does nature and extreme weather photography. I'm currently doing a Cert 3 in Screen and Media with the hopes of becoming a photojournalist. My journey so far, I struggled with repeated infections, and because of my complex health back in New Zealand, I struggled to cope and did not help me much. Due to my infections, I have been left with bronchiectasis, which is a progressive lung condition. I still struggle with frequent infections and extreme fatigue, which makes my daily life challenging, but I still keep trying. Once I moved to Canberra in 2019, I was then diagnosed with CVID. In 2020, at the age of 15, I began IVIG once a month. I now do speak weekly at home. The support I received in Australia has been striking. The difference has been striking compared to New Zealand. Due to my complex health at the time, I had a mix of specialists from both Canberra and Sydney. The support I had from both my medical team and parents have been instrumental to my care and overall well-being, especially as we learned how to come to grips with the realities that I would have to deal with throughout my whole life. As my medical needs grew, I began to require a greater number of Sydney specialists as Canberra's medical system struggled to cope with my needs. Due to that, we moved to Sydney in 2023. My highlights of my life. Since starting my treatments, I have still struggled with significant fatigue and regular illnesses, but even with that, I have been able to enjoy my passions, such as my photography, where I have won a number of photo competitions and suddenly begun a business out of it. Even with my difficulties, I have managed to successfully complete HSC, even when my school advised me to drop out in year 10, heading into year 11, as they said I would struggle too much and be unable to keep up. So because of that, I instead did pathways and completed HSC over 3 years instead of 2. As I've previously mentioned, my next steps will be completing my Cert 3 in Screen and Media and hopefully becoming a professional photographer and becoming a photojournalist, likely within the ABC. That is my biggest goal. Thank you.
Hi, my name is Lauren Downing. I grew up in Corowa, a small country town near Albury, Wodonga, and I was born with a respiratory issue, and that was later diagnosed as asthma. At 18, I moved to Sydney for university, and I built a corporate career in finance and insurance. But my health continued to decline. Doctors suggested I move to Brisbane for the climate, but it continued to decline further. They then recommended a year off in case it was corporate stress. Ironically, that was the year that landed me in ICU and isolation with multiple pneumonia, influenza, and Madagascan bird flu all on board. It was on discharge that the specialist told me having 10 or so infections per year was not appropriate and that I should seek new doctors. So months later, back in Brisbane, when I found out my GP was no longer practicing, I found a new one who changed everything. He asked, "How do you feel about your health and your treatment?" No doctor had ever asked me that before. I said I felt like I was stuck in a cycle of steroids and antibiotics and nebulizers, and it was like a Band-Aid solution. Then he asked, "Would you like to get to the bottom of the root cause?" Skeptical but hopeful, I said, yeah. At the time, I just started my own business, so I could definitely fit in the regime he wanted to put me through. 5 days into my new business, the diagnosis started rolling in. I needed stomach surgery for food particles that were entering my lungs, heart surgery for unexplained heartbeats, not due to my medication, 2 voice box surgeries, leaving me mute for a while. I was diagnosed with primary immunodeficiency or common variable immunodeficiency due to multiple immunoglobulins being out of whack, and that started me on 4 weekly plasma treatments. I had 3 surgeries for endometriosis and adenomyosis. We found HSV in my lungs, which explained the pain on breathing, and I got a late cystic fibrosis diagnosis. So after years and years of misdiagnosis, I'm in my 30s and I finally got answers. So by now I was having weekly plasma treatments to manage my peaks and troughs better, but my health did remain complex. I moved to the Gold Coast under the suggestion of my CF doctor to improve my health with breathing, and that definitely helped. However, I continued to have full body spasms and pain and rigidity persisting. Mid-2023, I had a significant painful spasm in my neck, and it lasted 5 weeks. And it was during this time I saw Celine Dion's news, and I emailed my doctor one Friday night. By Monday, we had a diagnosis that I too had stiff person syndrome. Not long later, I was having neurosurgery to replace my neck spine, and it was impinged into my spinal cord, and I was undergoing a variety of new treatments for SPS. My neuroimmunology team explained to me that primary immunodeficiency is a spectrum disease. Some are asymptomatic, whereas others go on to have multiple autoimmune, neurological, and cancer-based conditions, and it seemed that that was my pathway. It's not all doom and gloom, though. I feel like I've had a lot of key highlights because of my journey. I think in particular, I've lived a pretty ignorant life, well, up until my 30s. And the saying that ignorance is bliss is definitely on the money. I traveled the world a lot while I was younger, and in hindsight, I did some crazy things in third world countries that you wouldn't do with the knowledge that I have now. So that's definitely something that I'm grateful for. Many times I faced death, and most people would think that's awful, but I think it actually shifts your perspective for the better. I definitely don't sweat the small stuff, and I definitely enjoy the little things rather than the big things. Being born unwell also was a bit of a blessing, as I don't know any different. So I haven't gone through that shock factor like others do with a midlife change. I've been able to build a business to work around my health and adapt it as I need it to, and that's kept me living with purpose. I've formed friendships through my business and my health circles that I wouldn't have come to have without my circumstances. So that in itself, I'm grateful for. I've been honoured to support some organisations that are helping the future little Laurens get diagnosed faster. And yeah, I've got a lot of hope for my future. I've now recently been given the NDIS supports that I've been fighting for years. I've now got 7 specialists and 11 allied health professionals giving me the supports to literally function and stay on my feet every day. I kind of view my life like an iPhone upgrade. I'm always on the lookout for a new and improved way of living and a new and improved version of who I can be today, because every day is different, and naturally there's been deterioration and there will continue to be degenerative circumstances. So with that point of view, I've been able to keep readjusting the way I do things. And my dream is to continue working 10 to 15 hours a week in my business. One day launch a global online rare disease initiative, which I've built, but not yet had the energy to launch. I want to disrupt the medical industry. I want to push for faster diagnosis and better GP and specialist training. It should not take the 7th different respiratory doctor to get a diagnosis. You should be able to have a great GP. And meeting my great GP is what actually saved me, and I wouldn't be here without him. I live my life by the motto that he gave me that keeps me in check. He says, Lauren, don't suffer in silence. I live by that. And by that, when I notice that I'm suffering, that's when I call out to my squad and I keep chasing hope with them, because when you lose hope, you lose yourself. So if you are chasing solutions, then that drives more hope. And it is the hope that actually keeps you optimistic and can keep you going day by day. And I think that is crucial when living with a rare and unknown set of diseases. Thank you.
Thank you to all our speakers for the insightful presentations for this webinar. There are a number of resources through AusPIPS and IDFA, as well as other agencies listed on the slide, which can provide further information about the support that is available for patients and their carers, as well as active research programs operating in Australia. These include the National Immunodeficiency Strategy, research updates, and pharmaceutical research and development. We will share clickable links with you via our post-webinar email. Thank you for joining us for this webinar. We hope we provided some interesting insights into current and future direction for diagnosis and treatment of patients with primary immunodeficiencies. Our next AusPIP IDFA webinar will be in April to acknowledge World Primary Immunodeficiency Week, so be sure to look out for more information. In the meantime, keep an eye on our emails and social media updates for our new deep dive series. We would like to conduct a quick poll to gain feedback on the webinar, which we'll use in planning future events. I'll leave the questions open for a couple of minutes.